welcome you to this very important webinar. We open with the prayer in our national anthem, which is good for all of us. I think that is a better way to start, sir.
No, he mentions God. Okay.
Okay, all right. May I just ask our dear Papa, Professor Tayo, to give us an opening prayer?
Yeah,
Let's start with that. Let's start with that, sir.
Shall we pray? Can everybody hear me? Hello?
Yes.
Okay. Let's pray. Heavenly
Yes, sir, we
Father,
are hearing you, sir.
we thank you for this beautiful day that you've made, in which we are glad and already we are rejoicing. We bless and worship you for the rest of our night and for bringing us here full of life and expectation. Our expectation shall not be cut short in Jesus' name. As we commence this program, we do not pretend to know what to do. So we pray that you instruct us, teach us in the way that we shall go, and guide us with your own eyes, that each and every one of us, the speakers and those of us who are hearers and listeners, may be mutually beneficial, that will be empowered to communicate the information and the knowledge and our understanding to the Nigerian public, that we will not be victims of Ebola scourge and related scourges in Jesus' name. Thank you for those who are still on their way to join us. We pray that you remove hindrances from their path and bring them here on time, that they too may partake of these divine blessings. Thank you, gracious Lord, for we pray in Jesus' name. Amen.
Amen.
Yeah,
Amen.
you can sing your national anthem now.
No, that is okay, sir. Thank you, Professor Tayo. Thank you, sir. We're always proud to have you around at all times. Again, ladies and gentlemen, I welcome you to this very important and highly awaited webinar. We are 30 to 31 in the house now. I know many people have shown interest and they will come in. But our plan is to have an exciting webinar, a brief webinar. We plan that between now and 12:30, whatever it is that we want to do, we should have finished with it. Why are we here? It's not to make anyone fear. There is no Ebola in Nigeria right now. And by God's grace, there will not be.
Amen.
But we are here because we need to get ourselves ready. We have encountered Ebola before, and to God be the glory, we conquered it. Ebola is now in Central Africa and not too far away from us. And we don't want a situation where it will come knocking and we're not going to be ready. Already, it has become a serious matter in Congo with fatalities going in the region of 4,000 or 5,000 and so many other things like that. So our purpose is, how do we get ourselves ready? If, for whatever reason, for whatever purpose, for whatever circumstances, it knock on our door again. And that is why the Council of the Nigeria Academy of Pharmacy, as ably led by our president, Professor Larry Bale, set up a task group led by our never tired Madam Professor Fola Tayo. And this task group worked tirelessly to come up with this webinar. And we have lined up a team of resource persons. What we have done is to seek every area of perspectives, particularly as it relates to healthcare, so that what we have is going to be all embracing. We are going to have to be very strict on our timing. And I want to plead with all those that will be calling to talk, so please stick to the time schedule that we are giving to them so that we can finish this on time and be up here. Because what will happen is that all of us that will be present here, we will leave and become ambassadors of the country by telling everybody
consequently, preparedness must become a continuous cycle. We need to, that cycle is a cycle of anticipation, prevention, detection, response, recovery, learning, and improvement. Every outbreak should leave our healthcare system stronger than it found it. So what do we need to do? We want to move from webinar to readiness. We therefore hope that today's webinar will go beyond increasing awareness. As you listen to Dr. Adefolari Opawoye from the physician perspective, to Dr. Adewale Oludayo Akinpelu, from nursing, from Prince Eluchukwu Adibo, from medical laboratory science, and Mrs. Mudupe Adesanya from physiotherapy, and many others. I would like to encourage us to listen not only as members of individual professions, but as members of one interconnected healthcare team. Let us continue to ask ourselves, our facilities genuinely prepared? Do frontline professionals know what to do when a suspected case appears? Our referral and communication pathways clear? Can our laboratories respond rapidly and safely? Are healthcare workers adequately protected? Our emergency supply chains resilient? And critically, have we practiced working together before an emergency forces us to do so? Our shared responsibility, ladies and gentlemen, is that Ebola preparedness is ultimately about more than Ebola. It's about building a health system capable of responding to the next emergency infectious diseases, whether familiar or previously unknown. The lesson from this global health emergency is unmistakable. Number one, no profession can do it alone. Number two, no institution can do it alone. Number three, no country can protect itself through isolation. Preparedness requires collaboration. Readiness requires competence. Response requires coordination. Resilience requires continuous learning. And health security requires all of us. And on behalf of the Nigeria Academy of Pharmacy, ladies and gentlemen, we want to express our profound appreciation to our distinguished speakers, our participating healthcare professionals, everyone who has contributed to organizing this very important and timely program. We want to particularly acknowledge Professor Fola Tayo, who initiated this program. Professor Fola Tayo is very renowned in Nigeria as an academic, but in reality, in Europe, is very well renowned as a practitioner. So he is an academic who initiated this program and will provide the opening remarks and lead us through the synthesis and conclusion. We want to acknowledge as well Dr. Lulu Ojo, the Director of Program for the Nigeria Academy of Pharmacy, a man with several multiple uncountable degrees, and all members of the task force for coordinating this important healthcare professional engagement. May today's deliberation deepen interdisciplinary understanding, strengthen professional collaboration, and most importantly, translate knowledge into greater preparedness across all our healthcare institutions. We want to warmly welcome you all. Together with pharmacy, let us be the healthcare workforce that is not merely outbreak aware, but outbreak ready. I want to thank you, and God bless every healthcare professional, and God bless the Federal Republic of Nigeria. God bless you. Over to you, Lulu. Thank you.
Please appreciate our president. Please appreciate our president. Dot on the time, dot of time. Please appreciate him. Thank you very much, sir, Professor Lere Bale. And please note what he said, that preparedness is not a badge that we stick on ourselves and say, oh, 2014, we conquered Ebola. Therefore, we are ready. Let it come again. We are here. No. It's a moving target. So we must be moving too. Particularly now, the strain that is afflicting them in Congo is a different one, not the one that we are used to. No vaccine, nothing. So we must be updating our knowledge, getting ourselves ready so that whatever, we don't pray it comes, but if it comes, we're ready to fight. Thank you, Mr. President, for so expertly representing the
reference lab in Abuja. We have the Irua Teaching Hospital, which is a Lassa Fever Institute. They can all run these labs, but you see, we have one in Abuja, we have one in Lagos. We have the Redeemers University in Ede. They run Redeemers University lab in Ede that can run. That's ASEGIT. But that's more or less that's all for an entire country like Nigeria. If you have a case in Enugu, you're in trouble, because where do you send the samples to? So those are some of the challenges, because a lot of these labs are concentrated in very few areas. And also don't forget that many people self-medicate in the country with an overuse of anti-malarials and all of that. Many people, when they are sick, they present to the pharmacies, which is where we stand. And we are like a frontline surveillance system, because the way these things work, if you do not inform, nobody would know. If anybody didn't stand their ground and inform the authorities at the time, nobody would actually be aware of what is going on. So generally, we have an IDSR system. That's the disease surveillance response, integrated disease surveillance response that we use. And it goes from the facility to the DSNO, that's the LGA DSNO, to the state epidemiology, and then NCDC will take over at the end of the day. But it's domiciled the LG. And what we're trying to do this morning is that the pharmacists play a critical role in that. Now, know that we know better than I do that most people actually come to us when they are sick. We are the first port of call for them, before they go to any hospital. Many times people come to the pharmacy. And sometimes the pharmacist is the only person that has that conversation with them to know, okay, what's going on, what is wrong with you, and all of that. A lot of times these conversations are they are invisible to surveillance. These are going to help to sort of like pick these things early. So what are the things that we should do? You want to ask about sick contacts. So I developed a checklist I called Check. And you want to know, is this person having a fever, a true fever? And if you've used your Coartem for 3 days, you're good. If it's not going, it is something else. Some people say, oh no, that brand is pointed that there's maybe something more sinister going on. I'll be able to pick up some of this early. What are the action plans as we go? You must be able to have a plan if your pharmacy or your facility has a suspected case. How do you even know there's a... Now, remember that we don't have Ebola country yet. We don't know who will be the first to pick a case. The case may present to you first, to be honest. We don't know, right? The first case of COVID presented as...
Lost him?
No.
So,
I can,
I
brought him back. Yes.
I don't know if you can still see my screen.
Yes, we see your screen. Yes.
Yes.
Okay,
Yes.
thank you very much.
Yes.
So we must all have the access to our DSNOs. That's the LGA Disease Surveillance Notification Officer. And then again, we don't have a case yet, right? generally we are monitoring the borders. We hope that the case will not escape them. Pharmacies, if you have people who, are sicker than people that should come to you, you have a way of saying they are stealing a lot, then you want to be like, hey, call and be able to initiate a process. You cannot neglect that patient. You understand? You must be able to have a system. So systems work when you are ready, when you plan. Okay, if, for example, somebody comes to my pharmacy today or somebody comes to my facility today and has these problems, what are we going to do? Once you have that in your head, then when the situation comes, you are not panicking, you are not screaming at each other or looking for the blood of Jesus or whatever you are going to use at that time. So pharmacists are very critical because they are some of the most accessible people that we have. If you look at this pyramid, you can see pharmacists and patent medicine stores are at the base of the pyramid because you are the first hospital a lot of people go to. I remember during COVID, we had to do a lot of training to PPMVs and pharmacy, community pharmacists and all of that, because they are the first port of call to the people to like, look, when people come to you having breathing issues, please don't just give them salbutamol. The epidemiologist, of course, the laboratory, and then the NCDC takes over. So diagnostics is the one that catches the disease. Surveillance looks at the pattern, but pharmacists are the first line in many of these things. And part of our readiness is making sure that we can detect it and protect it.
Beautiful.
Thank you very much.
Beautiful.
Thank you. Please,
Wonderful.
let's appreciate our speaker.
Beautiful.
Let's
Beautiful.
appreciate him. Let's appreciate him.
Beautiful.
You know what? You've really, you did something which I need to say here. You are very calm, and that is what we want Nigerians to be. We want them to be very, very calm while expressing their concern. Thank you very much. Some of them while you're talking, but there is one that I need to ask you. So let's assume that a suspected patient walks into an ordinary hospital tomorrow. I mean, I use the word ordinary anywhere, healthcare center, whatever it is. What are those first three things that the attending clinicians should do? Those first three things that the attending clinicians should do. And what is that one mistake that must be avoided? Dr. Kwawe.
Basically, it goes two ways, right? Many times the challenges we have in outbreaks is under suspicion and over suspicion. And both of those extremes are bad. The question, and that's why we have what we call case definitions. Why are you saying that? Because you see, the challenge is this. Once you label a patient that, oh, I think you have Ebola, you have finished that patient, everybody will disappear.
Yeah.
In fact, pharmacy at that point will tell you of discipline with a high level of responsibility. Why do you even suspect that there is a problem? Okay, so you have a case definition. Your case definition says there are symptoms that are compatible. Unfortunately, the symptoms can be anything: fever, symptoms. You must have a history of exposure or an epidemiological linkage. Did you travel? So if I see someone now, oh, I'm just coming from Congo, you're having fever, Chama, that's all. I'll throw you to isolation. But you are in Nigeria at the same time, must not over suspect, because I've seen a lot of people die from fluids. Sometimes patient will not be able to run samples, will not be able to get blood for the patient, and then eventually the patient will die. By the time the result will come back from the lab, we discover it was not even Ebola. And there's this sense of, oh, we have failed this patient. So it's a balance. But the critical things you must do is to always confirm your suspicions first. Don't run around with the information that you have. Even at my level, I talk to 1, 2, 3, 4 people before I conclude. Because once we initiate a system, it's crazy. Some people will stop sleeping, will start running around from Abuja, call the state house, call everybody, we have a crisis. So it's not a diagnosis that you make with levity. So the first thing is to be well versed in the presentation of these cases, take a good history, and then be able to have a notification system and a proper pathway. Thank you very much.
Thank you, Dr. Kwawe. I got something from you here. We don't want any case
so impressed. But I saw something throughout your presentation that, yes, you may have the establishment, the whatever, the personnel, are they really equipped to face emergencies? Let me explain it. I left the UK. I'm back here now. 29th of June this year. I got to Muritala Muhammad International in Lagos with my wife. We had gone on NCDC, completed all the forms. It took us a time, and we got this NCDC, completed all the forms. It took us a time, and we got this our code to enter Nigeria. Surprisingly, we got to Muritala Muhammad Airport, and that morning, nobody asked us for our NCDC form.
Is a normal situation. That's the truth. People are not motivated to do their jobs. They don't understand the effects of negligence at that level. Sometimes they are bribed. Sometimes they are just paid to look the other way, So those are realities of the situation. We cannot deny them, But there's a lot of work that's also going on. There's a task force that has been raised. We have some funds that have been approved, about 10 billion, but in disbursement and actually use of the funds where it is needed. So all these are gaps that all of you as very powerful members of the community can talk about and stress on the government, and apply pressure so that the right things will be done. So to conclude, sir, I agree with you that we are not as ready as we should be. I always do a fire brigade approach, and that is not a strategy that can be relied on all the time. Thank you very much.
In the management of COVID.
Thank you.
Thank you.
Please appreciate him. Dr.
Okay. Thank you very much, sir. The topic before me this morning is Ebola prevention and control preparedness. Want to look at the North. Yes, sir.
We can see you very well.
Okay, the challenge I have is up to you because my own is not connecting. There's a network challenge here. So
okay,
I have it already on my.
I've asked Mrs. Lawa to share your slide.
Okay.
She will do it for us now, but you can start with your introductory note. She will share the slide for you.
Okay. All right. So, yes. All right. While waiting for the person to share the slide. So the topic is Ebola prevention and control preparedness. We want to look at the nurse's perspective. So I don't want to waste time because I know the previous speaker has spoken a lot and I have the introduction. Want to look at the history of Ebola, how it is being transmitted, but I don't want to waste time on this so that I can go to the main scheme. Then the diagnosis has been spoken. They've talked about the diagnosis. It's majorly we say.
It's been.
I think it's out.
Yes. Yes.
Tom Akinde
It's also.
is also out.
It's a gang up against our war.
They're actually in the same place. Yeah.
And national development, and him the prestigious member of the National Institute MNI honor in 2025. He currently serves as Managing Director and CEO of Lab Limited, an internationally accredited medical laboratory. For his exemplary leadership, professional excellence, scholarship.
Thank you very much. So thank the Academy. I thank you for the great work you're doing. Also thank pharmacist Fola Tayo for the platform. It was short. We are happy to be in every conversation in the healthcare sector, and I'm glad to this particular sector of in the laboratory. By way of introduction, I try to look at this as enhancing diagnostic and surveillance workforce capacity, because basically looking at the diagnostic capacity and the workforce, which is So I want to frame this conversation. I'll say that Ebola, for every Ebola response is at its core a test of workforce capacity. That's basically what it is. Previous speakers have talked about how workforce is key, how workforce has depleted. And your response is at its core a test of capacity for. Remember that vaccines and treatments matter. And that's where the pharmacists have their core, the vaccines. But most emerging pathogens, we still don't have idea of this. Remember that the strain of Ebola we're dealing with now is not responding to the vaccine and treatment plan that we used for the last one, which was Ebola virus. This is different. So you can't jump into it without having a trained workforce. So I mean, whether an outbreak comes from 3 cases to 3,000 cases depends on how well and how fast trained people can find it, confirm it, and act on it. So that's what we have: detect, diagnose, and respond. Next slide, please. So in the center of this, you see the laboratory in the middle in terms of the diagnosis. Without diagnosis, like my brother said, the doctor, you cannot start off anything. You can just be able to do quite a lot, and there's still a lot to be done, nevertheless. So if you look at the regional picture, which we all know, we don't spend time. My colleagues that have spoken have mentioned these. The Ebola outbreak confirmed DRC since 1976, they've had 17 outbreaks. So now, from the last outbreak to now, there has been the 17th outbreak had taken just 5 months, and is really great. Next slide, please, so that I can meet up with the time. Yes, please. So if you look at the spotlight on 2026 outbreak, you can see this. You can see the screen that confirmed cases over 4,945, and that's the Bundingio Ebola virus, one that is ravaging right now, very different from the previous ones, the other cases. You see from that graph, started from May, and then it goes astronomically to 4,000 something cases just within a short time. And the graph also tells us it's 6 provinces, 54 health zones, you know what that means, and then 2,325 deaths, which almost surpasses recorded deaths throughout the Ebola period, COVID period in Nigeria. This is just a very short time. And then for Uganda, 20 cases with 2 deaths. This is really worrisome. And it's not a disease we should look away from. It's not a disease we should treat kids like you will see when we get home to Nigerian perspective. Next slide, please. Thank you. So historically, throughout the 2014-2016 period in West Africa, recorded over 28,000 cases. But the Bundingio virus now in a very short time, 2026, you have 4,900 and something cases. And 26 is how long it has taken the 2026 outbreak to surpass the entire outbreak that took 23 months. That tells you the rate at which this virus is invading. And no country worth its onion will look away from this and feel it's not our time. That's why I really thank the Academy of Pharmacy for this very, very apt, and timely conversation that you've had today. So we should also know that the Bundingo virus, as of today, no licensed vaccine or treatment exists for it, unlike the previous one of the Ebola virus. Why is this important? This impacts on management. And this is key after diagnosis. And that's where the pharmacists play a big role. The case management, if there is no virus, there is nothing licensed, the treatment protocol and all that, that means it's something that the pharmacist and the entirety will have to have a research and a different way of waiting and anticipating the virus. This is very important slide. Let's look at it, and then we can see the underlying story. What is outbreak exposes about false diagnosis gap? I need us to remember that we must separate outbreak and preparedness. Outbreak must be separated from preparedness. There are two distinct issues, and now we're talking about preparedness. It's a different ball game when the outbreak is here. This is very key, and all of us must note this. What we do, preparedness, is different from what we do at outbreaks. So, underlying story is that this outbreak exposes our workforce. The first exposure is that no countermeasures to fall back on. Because there are no licensed drugs on this Bundingo virus strain that we're having now, it's a big challenge. Contact tracing is far below the threshold. Those in DRC, you need to look at it and then see the workforce itself is under attack. Imagine if 151 health workers involved, 41 killed, 44 died. The kind of mental torture, psychological pain, the entire workforce of the healthcare, like you and I, will be having in that part of the world now. The same thing will apply if such a fatality comes to Nigeria. And then the surveillance system, security and all. Imagine if this comes to a part of Nigeria where there is security. If the first case comes or gets to that point, you can imagine the kind of problem we'll have. So we must be able to anticipate all this to know the level of preparedness we must give as a country. Next slide. Now, let's look at the laboratories in the country. Cannot, as much as others like me, but it's a public health, concern, and there are specialized laboratories that can do this. And it lies the NCDC, who are the technical lead for all diagnosis and announcement of laboratories that can test. As we are in this country, there are not more than about 6 places. And those 6 places are not as skilled. They're not even centrally planned across the country. It's a challenge. Last time we had rescue from the Readiness University, Professor Happy's lab, Malabu's lab in Lagos. Now we have public health lab, of course, that's also been set up to biology level 3, because testing of Ebola is different from the COVID that we dealt with. COVID could be done in biosafety level 2, but Ebola needs biosafety level 3, which is more advanced and requires a lot more energy, a lot more, preparation, and a lot more organization. Now, from the moment one case is suspected, we must be able to look at excellent sample isolation. Only trained people can collect samples. Only trained people can effectively implement the infection control mechanism that is required for a suspected case. Only trained people can do this. Only few people can package the sample. Like I just told you that there are only few laboratories. They can imagine the whole country of 230 or 250 million. How the samples in suspected places can be packaged and sent to these few places without compromise to infection to others. This is very important. And then data system, how do the results come up? Surveillance data across NCDC and state epidemiology and laboratories throughout the tiered system. Remember our health system here from the lowest level of primary health care, secondary, tertiary, and then up to the reference laboratory system. Now, how do you, top data from the places where they are tested or where the samples are transported to the pyramid, which of course is the reference lab? It is very, very, very a big concern. And retention has been a problem. All the big guys that have been trained are now being retrained. And we can start a very big capacity gap. Next slide. That's what we should have done. Well, hopefully, we'll see whether we'll get to that. So where we stand today, the NCDC's composite national preparedness score as the middle of this year is 59%. This is not excellent. It could do better. They still remain the country's lead in technical lead. And we are happy that our president, inaugurated a task force. Our president, CFO, Bola Tinubu, he did this on 16th of June, and is chaired by Chief of Staff. Like my colleague said, announcing the 10 billion is one thing, and then letting it come out in terms of approvals and dispensing of the funds in areas needed is another thing. So the scores of the NCDC was across border surveillance, which we all know how cross borders are, from east, west, north, and south is a big concern. Laboratory diagnostic capacity is still quite low. This is the truth. It has to be improved upon. It's quite low. If we have the kind of surge that the experience in DRC, we'll be running better. And risk communication, health financing is something that has not been taken up as a consistent and a sustainable plan. Then don't talk about the health workforce. NCDC will test for this and they score 59%. This should be better actually, and we hope that when these things, if it happens, it doesn't, that we should be able to do better. Let's look at the others. The next slide. The honest assessment is that the gaps in diagnosis and surveillance workforce capacity. The early symptoms mimic malaria, like the doctor has said, and then this residual of delaying recognition at first contact. Pharmacists, you've been told how exposed, how a lot of us jump into the pharmacies at the first line, point, even the labs. I want to do a lab. I want to buy drugs. So both of us share, similar professional exposure in terms of, having the point of landing of the first case in Nigeria. It must not only be the way the soya came and the rest. It could be another way. And we should all be prepared. It could be a person jumping into the lab, I want to do malaria test. It could be somebody jumping in the pharmacy, I've been having this fever. What do we do? So we need to do this as a matter of urgency. Now, we also have to look at the genomic sequencing capacity, because, for us to detect the strain, we must have to have the capacity to genomically sequence. Because the only sequencing that can tell you the strain, if you are still assuming that the strain is the same, then you're making a mistake, because the strain of the last disease may not be the same of the one coming in. Even the strain that is in DRC now may not be the strain that we encounter in Nigeria. So it's only when you sequence, have capacity of sequencing, genomic sequencing, that you can study strains. And I'm happy to say that laboratories in Nigeria can do this study. But there are still few laboratories that can do this study, even in the private sector. But at the same time, it must still be consciously, Yeah,
Prince.
Yes, please.
It's okay, sir. I just want to plead that maybe you should begin to wrap up now.
Yes, I'm almost done. The next slide going forward. Yes, almost done. Next slide going forward is about strengthening the decentralizing diagnostic capacity. We must decentralize the capacity, must not remain in the place where it is. So the country can have enough reach, enough coverage. So we must secure the point of entry, diagnostic and solution readiness at the airports. Very key. We must have first point of landing testing capacity in Nigeria. There is no gainsaying about this. Biosafety level 3 facilities must also improve and it must also be increased. And the next one I want us to look at, next slide, please. If we're going forward, what we should do, we must institutionalize the following, then sustain the financing. We must institutionalize and sustain domestic financing for public health diseases and as well as other diseases. There must be a ring-fence budget line for outbreak workforce and laboratory systems. Because these crises are persistent, not only for emergencies or contingency arrangement, it must be a ring-fence budget system. And then One Health integration must be there. The One Health approach, bringing together the animal, the human, and environmental surveillance workforce, it must be coordinated properly. Ebola is predominantly zoonotic, and we should not lose that fact. And then the community-based surveillance must happen. And of course, we must embed the lessons of previous experiences for us to be able to go to the next stage. Now, this is just what it remains. We must detect, we must diagnose, we must respond, and we must sustain. And this is so important. We must sustain what we gained, like in 2014, so that we can do better in the years ahead. Next slide, please. Now, so this is what I have for the academy, Pharmacy Academy. This is the call for action I have for you. Please, can you go to that slide? It's very important. I expect that the academy will do the following. We as a strong voice in the country. This 15th slide, please. 15th one. One bit last. Yes, please. So the academy must advocate for a ring-fence multi-year budget line for outbreaks and workforce and diagnosis system. Not only emergency supplementary funding is not enough. We must recommend independent periodic audit and national preparedness that track workforce and diagnostic pillars specifically. And you must also support all systems that require laboratory training and, national curricula for CPD structures. We must also champion regular multi-hazard simulations, not just book simulations. Simulations must be done regularly so that we can be ready, just like the Atlanta facility that our colleague mentioned when he presented. When you make all these recommendations to the high places, then the government will hear and know that there is need to go beyond the style we are adopting for now. And the last slide, of course, I want to just say that 3 things are important, that resurgence is real and it's fast. We must not just say it's only prayer and fasting. Resurgence is real and it's fast. Nigerians proven we can do it and we can do it again. And then finally, the workforce capacity is the investment that pays every time. We must invest in our workforce, sustain them, and they must be ready at all times to respond, especially laboratory workforce for testing and also the workforce that must intervene in case management and detection. Thank you very much. I hope I can get some questions after this. Thank you very much. God bless you.
Oh, wow. Please, let's appreciate our speaker. Like I told you, he was just recently informed, I think almost just about 24 hours notice, and he accepted the challenge. And you see what he has told us. I listened to you, Prince Adibo, and I'm worried, I'm concerned. I wish Dr. Opawoye is still around, because my question, you have told us now, I will really ready if today Dr. Opawoye signed a sample with high suspicion that this may be Ebola. Are we in a position to actually confirm? You mentioned it in your presentation,
yes,
but hey,
yes, we
what
are.
is it that we must do now?
Only in 2 places, yes.
To get ready.
We're able to confirm, sir. I can say that with affirmation, correct, yes. But the matter is, the centers that could do this are few, and their skewness across the country is only towards 4 states. You can see the danger compared to 36 states in Nigeria. You don't know where the entry point could be from. That is a worry. But then that means that for you to confirm, you must still transport safely. You must still be able to have a trained person collect that sample of suspicion, it may not be from loot this time, maybe from an obscure border in north or east or any part of the world. No, sorry, Nigeria. So yes, we're able to. But the journey between the point of that suspicion and the laboratory that could have this capacity is still quite a very challenging one. Thank you, sir.
No, before you go, Professor Tayo has a question for you, but I'm still concerned. The concern is about workforce, and this was the question that Farm Monica wanted to ask Dr. Pawoye. You're talking about the Japa syndrome that has taken away our experienced people. I'm actually speaking from UK now, but I'm not on the Japa train. No, I'm just a grandfather who has come to visit. But so do we have that system, and not necessarily government now? I'm talking about laboratory. Do you have a system within your group to train and retrain our people in readiness for an emergency that may come? Particularly Ebola that we are talking about now. Is there a system like that to train
Yes,
and
please.
retrain our stuff?
Yes, please. Yes, please. The answer is yes. The NCDC, I must say, to a very good extent, on top of this matter. But the challenge remains the number, the ratio of trained people versus the vulnerable group of the entire country. Look at the ratio. So the ratio is not meeting the number that is required to be filled. Yes, capacity, yes, but the resources to make it, to scale is a challenge, sir. So this must be, that's why I suggested it, that you guys must be able to raise such voice to the government, to have such kind of secure finance that will make it continuous, not only when there is emergency. Preparedness is different from response. I'll keep on emphasizing this. So that is where the challenge is. Thank you, sir.
I get you. Well, that's why we are talking anyway. And a lot of people will hear us. We will publish, we will let them know for the laboratory, if the surge to come, the country is not ready. I mean, that's the point. So we need to now get ourselves ready, start building. It is not when it comes that we now start buying things, that we now start rushing to get this or that. Professor Tayo, your question for Prince Adibo.
Thank you very much, Dr. Luluoju. Congratulations, Dr. Prince Elochukwu Adiba, for that beautiful presentation. Very insightful. I've learned a lot. And I agree with you, and I want to extend your concept even further. What you're talking about towards the end of the day is about the need to collaborate within the health sector. Like your recommendations to NAPHARM, that's the academy, I want to extend it to all the healthcare professional groups, and I'm sure you'll agree with me. Rather than us throwing bricks and bats against each other, why can't we come together for the sake of vulnerable Nigerian populace? This your recommendation about laboratories. I was doing some calculation based on your presentation, your graph. I think is a number of incidents or so. I extrapolated from your second graph, and I think I got 166. I assume it's 166 occurrences over a period of, over a period of a month.
Yes, correct.
And that is very frightening. If you extrapolate that, within 2 years, you can exterminate a whole region or a whole local government. We cannot afford it. Why can't we, as people that God has graciously positioned in a place where our eyes are open, to think of Nigeria rather than I am a doctor, I am a pharmacist, I am a this, and that's rubbish. That doesn't pay Nigeria any dividend. Whereas if we come together, if you look at your recommendations, I can say that instead of the academy alone going to Abuja to talk to, what's his name now, Muhammadu Pate or President Tinubu himself, if pharmacy, laboratory, nursing, physiotherapy, medical record, medicine, and a lot. If we form a formidable team, maybe two from each professional grouping, and march to Abuja, it will intimidate the government, I'm sure. Even American government or British government, as powerful as they are, they will listen to you. But what's wrong with us? We know this thing, we can't do it. I'm appealing to those of us who are here. Our president is here. You can take the bull by the horn and set up this collaborating committee. Others may not want to join, at least 2 or 3 will join. If we are united, we can do a lot. Preparedness, yes. Now, if you have to take a sample, Irua Hospital, specialist hospital, has a good laboratory, whatever, as Dr. Opawoye, sorry, sir, and Dr. Adiba has said. Now, if you fly to Benin with that sample, Benin to Irua is about 90-something kilometers. If the road is good, it's okay. You can make it in 1.5 hours. What if the road is full of potholes? You can be there for hours, and a delay in such case can be deadly. And in our own case, it will be contagious. Let's begin to think of how we ourselves, those of us in the country, I'm only here temporarily. I'm too old to japa. You don't japa at the age of 80-something. You are going into your grave straight. But those of us who are in the country, who have made up our mind that we're going to remain in the country, come what may, because our reward will come. Let's make that sacrifice and come together. We are the people who can save Nigeria. USAID cannot save you. Already Trump has cancelled it. The salvation of Nigeria is in our hands. Let's do what we can to help our people. You people can run away from the country because of headache. There are millions of Nigerians that they have nowhere to go to, even when they have cancer. Please, let's consider it. Thank you, sir.
Thank you very much. Thank you, Prince Adibe. Can we appreciate him again? We really learned from you. We got the message, and the purpose of this webinar is actually confirmed by your presentation. Please don't give up. Let's keep pushing. Let's keep pushing. That is why we're alive. Yeah, we're alive in order to make the society better. And we must all do it together. Now, I want to go back to Dr. Ade Pelu, who we are sorry that Akinpelu, I'm sorry. We are sorry that that happened to you. And we just wrap up your part with some questions. Thank God that we have your presentation. We still do some good analysis on them. Now, we know that nurses spend the greatest continuous time with patients. So what must every nurse know about protecting him or herself, other patients, and colleagues if and when Ebola is suspected? Can we just have your feedback on this briefly?
Hello, sir. Please, can you repeat the question, please?
Okay, Dr. Kipelu. Yes, I'm saying that we know that nurses usually spend the greatest continuous time with the patient. So if we have a suspected case, what are those things that the nurses must do, the patient must do, other patients? Well, maybe you cannot isolate somebody that you have not confirmed anyway, and all those things. But if you suspect, what are those things that you must do to protect yourself, to protect other patients and colleagues if Ebola is suspected? What are those things?
Thank you very much, sir. Let me borrow idea from the Lassa fever treatment, because if there is a suspected case, am I audible, sir? Okay.
Yes.
We are hearing you. We are
All
hearing
agree with me that Ebola is more virulent. It's more virulent than Lassa fever. So the first thing I would recommend, if there is a suspect case, there should be a
I think this is an Achiever University network issue.
Uh-huh.
So Dr.
Oh.
Famakinde, Professor Vasman, Bola Olayiwola, and all of you who are there, you have to have some partnership with the network providers. Unfortunately, we could not have Dr. Akepelu again because there's another question I have. I will just put it on the table so that you can all consider it. You see, what kind of preparedness drill should every hospital nursing unit, what kind of preparedness drill should they undertake now, before a suspected case arrives? Because nurses are in their hospital. They are the one that you see, they're ubiquitous all over everywhere. So what kind of preparedness drill can they have, now before it comes? If Dr. Fama can they hear me, please put this on to Dr. Akepelu, and he can send us his answer. We will look at it and consider it. So we are moving on. We still have 2 more presentations, and I want to plead with the presenter. Particularly the next one, I want to plead with her because she asked us for an early time. We have moved on, sir. I will send you a note so that you can send us your response. I'll send you a note. I'll send a note to Dr. Famakinde now so that you can send us your response. Thank you. I know you made effort and we appreciate you because I know what is happening in there. So we appreciate you so much that you have made this effort to be with us. It's not your fault. It's network. We understand that. So thank you so much.
Thank you.
I want to call on Professor Bola now to briefly introduce our next speaker so that we can have her as fast as possible.
Okay,
Professor
sir.
Aina, are you there?
Yes, I'm here. Can you hear me?
All right. Very well.
Okay. Yes. Our next speaker is Mrs. Modupe Adesanya, a physiotherapist. And she graduated in 1987 from University of Ibadan. She's currently pursuing a doctoral degree of physiotherapy at Wesley University, Ondo. She spent some 35 years at Orthopedic Hospital Igbobi, where she rose through the ranks to retire as deputy director in 2023. She's a wife, a mother, a grandmother, even an author. She has some 2 books to her credit. Role of physiotherapy in orthopedic hospitals, which is a handbook for post-basic nursing students, and a book on when love is not enough, critical health and social factors to consider when choosing a spouse. Thank you, madam, for agreeing to present at this workshop.
Thank you very much for having me.
Let's appreciate her. Please, let's appreciate her. She actually told us of some other engagement and requested for any time.
Thank you. I'm not going to repeat what everybody have said. So in sharing my slide, I will just go to where it matters now. We've heard a lot. We've heard about the current Bundiguyo strain as not having any vaccine already on ground. So I'm not going to bore us with all those details again. I'm going straight to how can we prepare as multidisciplinary health workers. I'm going to spend just about 5 minutes with us because I have other engagements. So my approach will be, how prepared are we in training? Do we know how to don and doff the PPE, the PPE protective garments? I want us to look at this way. It is not the PPE you don that you are doffing in outbreak cases. The one you are doffing is totally, has a lot of contaminants in it. So how do we don? Are we trained as health workers? And my position is we should have a training facility, either departmentally or collectively. And I will suggest collectively, nationally. As people are trained to be managers, going to ASCON, I don't know whether they still go, we should have a training center for outbreaks where we can actually collectively know how to prepare for occasions like outbreaks that is beyond our control. So my suggestion, preparedness has to be national and has to be multidisciplinary. We cannot afford to be segregated. One person is running with his own idea and the other is running with her own idea. If one department is contaminated, all the efforts from the airports to the seaports to the wherever we are doing contact tracing and the amount of money that has been spent, everything will go to waste. If just one person in the health sector, and it doesn't even have to be professionals alone in the health sectors, even the cleaners need to be trained, because they go in, they come in, they bring files to us, they do all sorts of things. So if we are looking at preparedness, it should be all health workers. And we need a decisive place where training on outbreaks will be done. That's number one. Number two, in our continuous professional development, outbreak training should be one of what we are being trained to do. Then going back to the academics, thank God Professor Fola Tayo has already spoken that we should include outbreak training, infectious disease and control into our curriculum from the school level. Before people graduate, they should know how to prepare for outbreaks, for emergencies. We cannot wait until another one happens. We don't want another Dr. Adadevo. We don't want another victim. All we want now is all health workers must be protected. And I want to say that survival is not just being it's not only to be a survivor. As physiotherapists, we need to know how to deal with even bringing health workers back to shape, back to health, in the way we prioritize our recovery stage. After people have survived, it has been documented that a lot of people have post-Ebola sequelae, ranging from headache to eye disease, to weakness of the muscles, to joint pains. How do we handle those things post-survivor? So we need, as health work, as physiotherapists, to train how to handle, because this is not a regular musculoskeletal disease, it's not a regular joint pain, it's not arthritis. It's a sequelae from Ebola or from any other outbreak. So how, as a physiotherapist, do I need to handle my cases? You know, physiotherapy is a hands-on, in fact, it's a body-on. Because as a physiotherapist, your body is a tool. You carry your patients. They have direct contacts with not just your hand, but with the whole of your body. But in cases of outbreaks, in cases of highly infectious diseases, how am I supposed to position myself so I don't get infected? So as a physiotherapist, your donning experience, your donning knowing how to don and doff the PPE is not something we can joke with. We have to take it with all seriousness. And the only way we can take it with all seriousness if we are trained to do that. And I'm looking forward to a nation where there will be training institutions for health workers to be able to prevent themselves from getting infected with whatever is going on at any given time. So our preparedness as health workers should not just be when the Ebola or when the virus is already near us, as it is right now. If it is in Congo and our people travel a lot, as it has been said severally, we don't want a situation where we are taken unaware. Like Professor Fola Tayo said, when a cripple knows about the war that is being announced, it takes his journey right from the minute he heard about it. So if Nigeria has already heard about Ebola that has no vaccine in Congo, I think the training should begin now. We should not wait again. So saying that preparedness is about training, let us begin to train. So at departmental level, let's begin to train. As individual hospitals, let's begin to train. Then let's begin to inculcate preparedness into our curriculum. And I'm going to leave us with this. Now, Nigerian physiotherapists are not in the infection protection and control units. They are not integrated in that preparedness. Physiotherapy are standing alone. Meanwhile, in terms of body contacts, we are the ones that are mostly in contact with any patient we treat. So the policymakers should look at including physiotherapy as a profession into the infectious disease and control unit or team. It should be a team approach. We should not be left out. If government's decision does not include us, we will be working alone, and we should not work alone. So the policymakers, please include physiotherapy as part of the workforce that should prepare in training, in remuneration, and everything. And health workers will be able to be treated. We will be able to treat health workers who are victims. We'll be able to return them back to work by even knowing what we should do to cases that are to people that are already survivors of any form of outbreak. The way you handle such patients is totally different from the way you handle a regular musculoskeletal case. Is different from the way you handle normal arthritis and all that, because you need to keep your distance while you are still attending to these patients. And I want to say that since we all know now that Ebola does not have vaccine, and the only way out is to guard against it. To guard against it in the sense that we need to protect ourselves so that we are not victims. How do we identify cases? Because by the time a patient is coming to you as a physiotherapist, he has gone to several other departments before you. So if peradventure other people miss this case, when you as a physiotherapist are clocking your patients, you are assessing your patients, one of the questions that must be asked, if not the first one, is your travel history. We need to know whether you have just come from somewhere. So putting all that in our training as physiotherapists is sacrosanct, because Ordinarily, as a physiotherapist, you won't be asking patients, did you travel yesterday? Did you just come back today? But now with the current situation, that should be part of our history taking. So once again, I want to implore policymakers to include physiotherapy in the training of any form of outbreak in infectious diseases, protection and control. I'm going to leave this stage now. I will spend another 2 minutes if there's any question for me. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am. Can we please appreciate her? Can we please appreciate her? Madam, you can see that those of us in the academy, we are already thinking and collaborating with physiotherapists because we see that healthcare is a teamwork. And if there is an outbreak, we need everybody. And the question I want to ask is the one that I've addressed, but let me still say it because we have journalists in the house. What we are doing is not only for the healthcare practitioners themselves. The people that should also know are Nigerians. You know, those that are vulnerable, you know, to what we are talking about. Everybody is. It applies healthcare practitioners too. So when I mentioned to the journalists that we have physiotherapists, we have the first question they asked me are physiotherapists. What have they got to do with Ebola? And that is my question here. Physiotherapy is not the usual first profession people we associate with Ebola. So that question is, where exactly does the physiotherapist now fit into the preparedness that we are talking about, acute care and recovery? Where is the fit?
Thank you for that question. Physiotherapy fits into all levels of care, from acute, because when these people, when they come in, number one, anybody, like I've just said, anybody can miss that diagnosis. A physiotherapist might be the one, while interacting with this patient, while asking your question in your assessment, you might be the one to pick this. That's number one. Number two, musculoskeletal issues may start, maybe even the first sign that we tell you that this person has something more than just the normal, regular pain. In the preparedness, physiotherapists need to know, like I've said before, the signs, the symptoms. If they don't know, how do they pick it? So we need to know all the signs, all the symptoms of any form of outbreak that might be coming, even the Ebola that is on ground now. So any health professional should be able to pick it at any point. Then the treatment of all this sequelae that comes with Ebola, physiotherapy needs to know how to treat them, how to grade the kind of exercise you will give them, and how to escalate when you come in contact with a, if you don't suspect, yes, we are not going to over-suspect. So physiotherapy needs to be integrated in the system.
Okay, thank you.
I don't know if
no, you have done well. Thank
question.
You very much, ma. We appreciate you. Please appreciate her again. We thank you so much, ma. We are doing well. It's 12:14 now, and our plan is to wrap it up by 12:30. But we know we gained some time, we lost some time. So all here and there. Professor Tayo, you have a question for Madam before she goes?
A question and a comment, more like a comment. I agree entirely with Mrs. Adesoya. The physiotherapists, even at the community pharmacy level, the physiotherapists and the community pharmacists they should work in collaboration. I remember several years ago in the UK, that must be in the late 60s or early 70s, I was a Boots chemist manager. A lady came presenting. She wanted something to relieve pain in her legs. Known in those days, it hasn't been synthesized. Dispensary, salicylate, that's right, sodium salicylate and some other things, aspirin derivatives. And I rushed into the dispensary, boom, 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 boom. I gave her, she rubbed it in. A week after, she came in and I recognized her. I said, Madam, any problem? She presented the same thing. I became curious. I told my Oga, the pharmacist, say, give her the same thing. Maybe she hasn't used it long enough. I said to myself, sir, this could be more than what we can handle. He said, you can't send her to the hospital with this. I said, okay, there's a lady who worked at St. George's Hospital, a physiotherapist. Can I call her? And we sent this woman to the physiotherapist. Unknown to us, she spent the next 10 years in a wheelchair after she saw that woman. I'm just collaborating your point that it can happen at any time. They come, you detected fever and some muscle pain. A muscle pain can speak volumes. It's just like simple headache. We call it simple headache. Headache can be my earlier point, is the need to collaborate. And I recommend, sir, thank you, Mr. President is here. Form a team of all the healthcare workers. Form a team and go to the government. They will listen to us. Now I'm wiser. If I had to live back the years I've lived, I will go in the company of at least 2 or 3 other healthcare professionals. They will listen to us. We have a minister of health who can listen, is prepared. That's Patty. He's been in these shoes before. He's an experienced person, very bright person, and very welcoming. I recommend that we approach him. Thank you, sir.
Thank you, Prof. Thank you, Madam, for being with us and for your presentation. We appreciate you. We appreciate you. Now we are getting almost to the end of our presentation, and it's now going to be pharmacy perspective that we're going to be looking at. Let me call on my dear friend and sister.
Good afternoon, everyone. And it's an honor for me to introduce my colleague, an accomplished consultant community pharmacist and public health advocate, pharmacist Mrs. Fola Tayo Olufunke Lawal. She has proved herself a public health advocate, actually, who has championed many causes in her practice of pharmacy. She is the founder of Victory Drugs and also the proprietor of Victory Vaccine Clinic. She has collaborative publications in international journals. Apart from that, she owns a lot of online health community groups. Example, Victory Diabetes Group, Victory Mothers Group, Victory Asthma Care Group, and Victory 50 Plus Group. And she holds a lot of membership of professional bodies, among which she's the West African Society for Parenteral and Enteral Nutrition, WASPEN. And she is also a member of American College of Clinical Pharmacists, ASPEN, among many other professions. For lack of time, we will not be able to expand all the achievements she has accomplished, pharmacist. And I want to really also stand with the statement that Dr. Kwawoye made that when it comes to outbreaks, the pharmacist or the pharmacy represented by the community pharmacist seems to be the first port of call of a lot of our people, as both in the rural areas and within the urban areas, because the way our health systems have been programmed, we don't easily go to the GPs. So the community pharmacists are key in this fight or preparedness of Ebola disease. So having said so, I want to use this opportunity to invite our astute consultant community pharmacist Mrs. Fola Tayo Olufunke Lawal, to really look at the aspects of various areas of pharmacy. Thank you so much.
Thank you. Please let's appreciate Fola Tayo Olufunke Lawal. For almost 50 years, I've been used to calling her Sade, but she told me it must be Fola Tayo going forward. So please appreciate Fola Tayo. Yes. And I've seen some hands up. Mr. Faniron, I've seen your hand. I'm going to call you. The president of the medical laboratory group is in the house. I saw your comment on the chat board. That's quite good. So I appreciate Fola Tayo so that she can come in and talk to us. Then as we're rounding up, if anybody has something to say, you let us have it. Okay. So Fola Tayo, over to you.
Thank you very much for having me. Good afternoon, everyone. I am also part of the organizers, so it's a privilege that I have to take us through pharmacist perspective. I've been asked to complement what others have said as much as possible and get it down to the public. So those are my major interests here today, this afternoon. And I will try as much as possible not to repeat what has been said, while I also break it down to the public. So permit me to share my slides. Strengthening pharmaceutical workforce preparedness during health emergencies. A lot has been said, and I'm happy that we're looking at collaboration as far as preparedness is concerned. I'm happy that we want to bring in as many healthcare professionals as possible. Permit me to add that we should also consider clerics. If we remember the Sawyer story, he was going to the church. And if he had succeeded, I don't know what would have happened. So there are many healthcare emergencies, disease outbreaks, environmental disasters, humanitarian crises. Why this matters a lot is that healthcare emergencies place unusual demand on the pharma workforce. That's why it matters a lot to us. And then frontline workforce preparedness is not optional. It's a life-saving infrastructure. Community preparedness saves lives. We must prepare as a community as well. Let's just take a brief look again at the Ebola virus. Incubation period 2 to 21 days. Transmission is via direct contact with fluids, either the fluids from the animal or the human vector. Symptoms are usually non-specific. They include fever, joints and muscular aches, sickness, diarrhea, and vomiting. And may mimic malaria, especially in our own climate where most things are swept under malaria and typhoid. I often say that if malaria and typhoid could sue, they would have made money from Nigeria. Ebola is not like COVID. It does not spread through the air like COVID. It is through direct contact with body fluids of somebody who is sick or has died from Ebola. Ebola spreads only after symptoms begin, unlike COVID. A person with Ebola is only contagious when they begin showing symptoms of the disease. We need to hold on to that. Now let's look at lessons from Ebola. A lot has been said. The rapid spread, the high fatality, the community fear and misinformation. We had that the last time we had Ebola outbreak. A lot of misinformation. People died not from the Ebola, but from panic measures that were completely unscientific. Pressure on medicine supply chain. Many people want to start taking just anything anyhow once there's an outbreak. Then there's the need for coordinated response. We've said that. I appreciate all speakers. They've done a lot of work. They've done great justice to it, and they've made mine very easy for me. So when we're talking about the pharmaceutical workforce, who are we looking at? We're looking at the pharmacists. We are in academia, we're in industry, hospital community. We're looking at the pharmacy technician, supply chain logistics personnel, and other pharmacy staff. It's been we cannot overlook the fact that we are usually the first point of contact for patients. And we see those who are symptomatic and asymptomatic. People who visit the pharmacy sometimes are not even ill at all. And that's why we're a very good hub for preventive health. Core roles during health emergencies. Let me briefly take us through that. Our core roles are to ensure medicine availability, accessibility, and rational use. Very important to ensure that the drugs are being taken rightly. Infection prevention and control support, public education and risk communication, collaboration with other health responders. That's the way I put it, not only healthcare professionals. Collaboration with other health responders involves community and communication and partnership between pharmacists, nurses, doctors, public health authorities. Like I said, we might need to include clerics. We are very religious people. Reliable channels for receiving and sending emergency alerts. We have to define referral pathways, clear roles and responsibilities. Now this talks to ensuring medicine availability. For Ebola right now, the current strain, there's no medication that cures it. But the symptoms are the major issue, and we need to be able to supply supportive care medicines like ORS because of the diarrhea, vomiting, analgesics, and antibiotics. It's important that we don't have stock out on any of these. Going to infection control and safety protocols, a lot has also been said, but I want us to focus a little bit more on the public. I recall Ebola time, people almost took their baths. In fact, some people had their baths with hand sanitizers because of the fear. Hand sanitizers became so scarce and expensive. We had to, as pharmacists, come together. The University of Lagos, I recall, because I'm in Lagos, pharmacy, they produced hand sanitizers to meet the emergency needs. But as soon as Ebola died out, hand sanitizers died out. And that is the least protection we can give ourselves. Our hands, our destinies are in our hands. We must be able to wash our hands properly. We must be able to keep our hands germ-free, because many germs travel from our hands to parts of our bodies, and we pick them up easily. So it's important that we focus a bit on that. We, as pharmacists, we go out to educate, let people even embrace simple hand hygiene, good safe disposal practices, and people coming into the pharmacy, we should be able to help them to learn safe practices. Now, I have this video that I want to play that will talk to us about our hands. What I've done is to simulate germs, and then we can see that we cannot see these germs on our hands. Many times you hear people say, my hands are clean, and they will not wash. Let's look at this. Let's just go through this. I pray, please.
This is to demonstrate to us that we might have germs on our hands without knowing that we do. I have applied a lotion that simulates germs. You can see my hands, they appear so clean. They appear clean. Then put them under this UV light that is like represents a microscope. You can see germs. Then move it out again. They are clean. And move it in again. You can see germs. So these are germs. We have germs on our hands. We don't need as many of these germs. If they were real germs, to get sick. A little bit is enough to make us sick. So to wash our hands properly, the first thing I want to do is put the tap on, wet my hands a little, and get enough soap in. So I wash properly, scrubbing, because germs can be hiding anywhere. Then I wash this through scrubbing. Then I go to the back and wash, taking note of all the areas where germ can be hiding, because it's important. We just need one to start off the ear health. I wash here properly. I wash my nails, nail beds, make sure that there's no germ anywhere. When I'm done washing properly, front, back, in between, anywhere the germs can be hiding. Awesome.
Beautiful.
Now that I'm done, so I don't get my hands infected, I use my elbow to close it down. I can air dry, or if it's possible, towels, I'll use them to clean my hands and dry. I wash my hands and they are dry, and back to this device, you can see my hands are clean.
Very good.
This is to demonstrate.
Was that viewed for everyone? Am I being heard?
Yes.
Okay.
We can hear you.
So I want to talk briefly about community fear and misinformation. That's having their bath with salt or hot water prevented Ebola. Some people even drank a lot of salt and they died from that. Ebola is caused by witchcraft or spiritual attack. That's also a myth. Ebola can be cured by drinking salty water or eating bitter cola, which is also a myth. It's okay to touch and perform burial rites to a person who just died from Ebola. We just said that you can get Ebola from the fluid of the living and the dead. There's nothing like Ebola. It's all a scam. Some people were in denial, which is also very dangerous. And that is why all hands have to be on deck. Let's look at the preparedness gaps. A lot have been identified, and I don't mean to repeat them, but let's just remind ourselves. So optimal emergency response training, we just must have the trainings. It has been said that it's better we have not. Left to me, this training should even start from primary school. We can inculcate training on taking preventive, taking care of ourselves, personal protection, right from primary school. Not enough integration into national emergency frameworks. That has also been addressed. PPRD about safety gaps, supply chain vulnerabilities, communication gaps without care with other health systems. I'm sure by God's grace, this will be addressed way forward. I trust that we do better than we were doing before. Then we need to debunk public misinformation. We had this poster that we prepared at the academy that will help us. It also talks about where to go if we have any case that we suspect. The importance of preparedness is summarized here. Preparedness gives us readiness, then prompt and right response. what we need to do going forward. Before a health emergency, what do we do? Let's train health workers, conduct simulations, develop SOPs, establish stock systems for emergency, clearly define roles, very important, build communication networks. And during the emergency, we activate the response plans that we have, protect health workers and clients. Everybody deserves to be protected. We should not have another adventure. We should maintain medication supply, health teams, and after the health emergency, we should evaluate response, document lessons learned, and address the gaps of this emergency plan. When we talk about strengthening health facilities for emergency preparedness, it behoves the government to strengthen healthcare facilities with people, the right professionals, medicines, equipment, PPE, training, surveillance, and funding. Government investment in healthcare facilities today strengthen our ability to detect, contain, and respond to Ebola and other health emergencies. Tomorrow, these are my take-home points. Fever is not malaria. In Nigeria, fever, the many public, more often than not, what we see in community practice, the moment somebody has a fever, they come in to say, we have malaria. Fever is not malaria, it's just a symptom. And it could be a symptom of so many things. Headache is not typhoid fever. Headache is a symptom. It can be a symptom of so many things, including Ebola. Diarrhea may not just be food poisoning. It may be a symptom of something bigger. Ebola is not a death sentence, no. Early detection and right action increase the chance of survival. So if you suspect that you have Ebola because you have a travel history or whatever, please access care as soon as possible and let's know what's the reason. Ebola is preventable, and that's why we're here today. Get credible information from your professionals, NCDC, WHO, or CDC, not social media. I'll conclude by saying that we all have roles to play in preparing for health emergencies, everybody. Early detection, prompt, and the right response can save lives, protect communities, and build a healthier nation. Preparedness is not a choice we make when an outbreak begins, no. It is what we build before it happens. Thank you all for listening to me. Thanks to God bless us all. Before I round up, permit me to particularly acknowledge this doctor, Dr. Stella Ameyu-Adedivo, who worked at First Consultants. A lot has been said about her too, for preventing the nation from that catastrophe, aided also by government. We do not want to have another incident like Dr. Stella Adedivo. We want everybody to be alive and safe. Thank you.
Thank you. Please let's appreciate from Fola Tayo Olufunke Lawa.
Beautiful. Beautiful.
I hope I didn't miss anything this time around, my sister. Let's appreciate. Let's appreciate that. Let's appreciate that. Thank you so much. I think this speaks to what we've been talking about, and she has actually showed us what to do. Practically, showing us how to wash our hand. She said something which I actually recollect. Ebola left. Thank God that we successfully fought Ebola. Then our hand sanitizer left too. We stopped sanitizing our hand. Even at the airport, everywhere, public places, all those things that we put in place, they all left. Thinking that's the end of it all, which we should have actually made part of our routine so that it can be okay for us. Now, time is gone. We should have finished 10 minutes ago, but I believe that we're enjoying what this is all about. Now, I have any questions for you, but I will only ask one, or worst case scenario, two. The first one is community pharmacists may encounter a worried or symptomatic person before that individual reaches hospital. I think that has been established. It has been clearly established that people visit the community pharmacies quite often before they go to the hospital. What precisely should the pharmacists do when Ebola is suspected?
Thank you. There was one poster I showed in my slides. I don't know if I can call it up again. It's very detailed. There are lines that we can call when we suspect Ebola. Like we have established, we should not under and we should not over suspect. But when we suspect, it's safer to refer. So what we need to do, first of all, is assure safety of everyone around. We might need to counsel this patient to sit somewhere while we attend to other things. But it's important that we don't scare the person. It's important that we don't stigmatize this person. It's important that we try to explain that we want to help this person access care as quickly as possible, because we're not sure. We're not trained to diagnose and we're not diagnosing. We don't know what the issue is, but this person might have some problems that need more than we can do. And then we relate with the appropriate quarters to get the patient.
Okay, I am aware of this. I mean, you said it, you have that unique advantage of being a member of the task group and a resource person. Now let's go back a little in time. COVID-19 has showed us the danger of waiting until the global emergency before competing for scarce resources. We all know what happened that time, how we had to line up to get the vaccine, even the sanitizers. Thank God that a lot of our colleagues responded well to that. Our universities responded well to that. My question, which I just want you to give us a light, what should Nigeria stockpile now? Manufacture locally or preposition for, and who will be responsible for that?
Okay. Since there's symptomatic management, and that is key, because the lecturers have to be balanced and all of that, I think that as a nation, we should ensure that we have those emergency medications, those drugs that might help with the symptoms. We should also focus a lot on prevention. And that's one of the reasons we are here today. We should sensitize the public, help them to understand what Ebola is all about and how they can be protected. Prevention is one thing that we should spend a lot of our energy on. Then we should train people or help people to understand why they have to be very hygienic, especially with their hands. Let them know that germs are not visible to the ordinary eyes. I come across that a lot. Many people will tell me my hands are clean because they cannot see the germs. Viruses are not visible to the naked eyes. The bulk of it will be on government to help out because funding is key. There has to be a lot of trainings, the equipment have to be available, and so we need the government to drive that. That's my thoughts.
Okay, thank you very much. There are questions for you because I seen some hands are up. Professor Tayo's hand is up. I don't know, sir. Maybe I should pick this so that we can move from your question into general question and answer session. Because now we've heard from 5 perspectives. We've seen what we need to do. The laboratory perspective, let us understand that we are not there right now. And I sincerely hope that those who are concerned know about this. Now, if a suspected Ebola case enter Nigeria tomorrow, what is that one weakness in our present system that each of the people that have shared perspective with us will want us to correct immediately? I don't know how many of them are still available. If they are not available, I will ask Professor Tayo to respond to that. What is that one weakness in our present system that we may have to almost immediately now handle? I don't know whether any one of them is around.
Yes, I'm here. Dr. Divo is here.
Okay.
Thank you. So one weakness I think the country should address if Ebola comes tomorrow is the reactive preparedness. We should be proactive and we'll be on the waiting for anything. The stimulations and all, everybody should be ready on his own part. So it should not be like, oh, is everybody running helter skelter? Yeah, there was time to prepare. So if that's that reactive preparedness, I think we should change it to a bit more proactive, and simulations should be done. More live simulations should be done to keep us as ready as we ought to be. Remember Prof's experience with his wife. What about if anybody had Ebola in that flight? We thought, oh, it's not coming yet. It's not coming yet. There's no announcement of the time to come. So we just have to be very, very watertight prepared all the time.
Oh, thank you so much. Reactive preparedness.
Yes.
Reactive preparedness. Because my associated question is, most of the talk that we are making now revolve around Abuja and Lagos. What happened if the first case, happened in a remote village? A remote village, what is going to happen to us? How many people would have been infected or would have lost before we get to know? So, Professor Tayo, your question now.
Yes, the question you asked Fola Tayo, which Dr. Adiba answered, I want to reframe it. You ask for, say it again.
I asked two questions.
No, the last one.
The last one, okay. I said COVID-19 saw us the danger of waiting until a global emergency before competing for scarce supply.
Yes.
What should Nigeria stockpile? What should we manufacture locally or preposition for now?
I think that's very all-encompassing. Let me chip out that bit about what should we manufacture. I remember as Pro-Chancellor of Caleb University, at the outbreak of Ebola, everybody was running helter-skelter. It's a residential university, and we had about 5,000 or 4,000 young adolescents in residence. And I told council, these people are our responsibility. What shall we do? There was no viable answer. I said, okay, we can do something. We have a chemistry department. Fortunately, I'm a pharmacist. I will write a formulation for you. Chemistry department, HOD, and your people, prepare this thing and put hand sanitizer that we prepare in Caleb in all the corners, nook and crannies, the toilets, the hostels, everywhere, even the lecture theaters and the registry and everywhere, and in other places, and the cafeteria. And let's hold a meeting, not a seminar, a meeting in which we will explain to students the advantages and disadvantages of cleaning your hands and demonstrate, as Fola Tayo has done here. Ours was not that perfect, but at least we achieved something. Throughout the Ebola crisis, that was about 2 years, 3 years, we didn't record a case of Ebola in that university. That has encouraged me to ask questions. What is our pharmacy faculty doing? Lanre Silva at Idiaraba, he was doing it for people. Why can't Lagos, Olabisi Onabanjo, Ibadan, Ife, they are close by, come together and be a formidable force to produce hand sanitizers for this sector? Benin, Port Harcourt, Elele, and others for the South, Nsukka, Enugu, and others for that, and then go to the north and split them. Even if the government is not interested, I get angry when people think government should do everything. We know the kind of governance we have. Are we going to wait till all of us die before we take action? Let's do something. The government will be, I don't know whether convicted, or the government will realize that Nigeria has a large capacity that is lying low, doing nothing. And somebody needs to ginger it up. And I think the academy, like I've said, collaborating with other healthcare professionals, people of like mind, we can springboard and show Nigeria the way to advance. If you study the history of industrial revolution in various countries, even political revolution, they were started by not everybody, just a few people who have a purpose and they have a like mind. Again, I'm advocating, sir, before we end this thing, if that's the only take home we have, what does it take to prepare hand sanitizer? You don't need a large scale machine to manufacture whatever. Small scale, distribute in that area free of charge. If we advertise that we need people to contribute, some of us will contribute from our widow's mite. 1,000, 10,000, 1 million, we will build a formidable force that will be a bank for Nigeria. I see you now sanitizing your hands. You need a sanitizer
all around me. It's like sanitizer all around.
That's my plea, sir. And I appeal to all of us to consider it, because very soon some of us may be coming to you for donation on behalf of the faculties of pharmacy. Thank you.
Thank you, sir. Thank you, sir. Thank you, Prof. I know you have been so concerned about this. Thank you, everybody. We have 82 in the house, even as at this time, and we have spent more than 24 minutes beyond the time that we plan to stay here. But it is worth it. It is worth it because we may not control when a threat will knock, at our door. We may not control it. Those may not be under our control, but we can control how prepared we are, when it does, and that is the reason why we're having this webinar. The floor is open. You want to say one or two things briefly? Anybody in the house? Is Mr. Fanino still there? Your hand has been up for a long time. He's still in the house. Felix Fanino, will you introduce yourself and make your comment?
Thank you, sir. I'm Dr. Felix Olukayode Faniro. I'm a retired director of physiotherapy at the Obafemi Awolowo University Hospital, Ife. Currently assisting as acting HOD, Department of Physiotherapy, Wesley University, Ondo. I'm quite delighted to be invited to this seminar. It has been handled so far. I believe this country has a very great future. One of the questions that was asked, presumably by journalists through the moderator, concerning the role of physiotherapy in the management of Ebola or similar things like this, is a very important question. And it shows actually that media and the entire members of the public, most members of the public, do not know so much about the role that physiotherapists play in healthcare delivery system in modern times. Most people, even those, some of us in the health sector, still feel that physiotherapy is only concerned with rehabilitation. But that is no longer true. Physiotherapy has a lot of role to play at every level of life, whether one is sick or apparently healthy. The physical therapist today is trained to promote health, to prevent diseases, to examine patients, to diagnose him or her, to rehabilitate where necessary, reevaluate and discharge. You will agree with me, in these roles that I've mentioned, physiotherapists have played a significant role in minimizing the effect of Ebola and other things, in not only in Nigeria, in other parts of the world. You will recall that the Prime Minister of UK was involved, and he asked to thank some of the people, frontline workers who helped him. Physiotherapists was one of them. Physiotherapists have come down as some of the people who have suffered serious calamities, who have died managing Ebola cases. But today, it has been documented that exercises play a significant role. When people are involved, are given exercises, majority of them develop higher immunity that enable them to be able to overcome the disease. So every person requires a physiotherapist at one time or the other, whether as a child, a baby, or a geriatric. Therefore, the case made by Dr. Adesoya in our presentation, the physiotherapist presented there, that policymakers should integrate physiotherapists into the care is absolutely necessary. In fact, at the national level, there should be national policy on physiotherapy now, after 81 years of existence in Nigeria. So having said that, let me add quickly to what Professor Fola Tayo has said. I agree with him entirely that there should be a team of all people concerned and working together. It's high time we do away with the big cranes in the health sector. It is by working together that we can help this system to grow. Once again, I thank you for giving me the opportunity, and thank you for this organization. Thank you.
Thank you very much. Thank you very much. Dr. Akpa, I have seen that your hand had been up, or is it lower now?
Yeah, thank you for giving me the opportunity once more. I think Dr. Felix Faniro had said what I wanted to say. My focus is on Federal Ministry of Health. The president has announced that 10 billion had been released for Ebola preparedness for the nation. I'm just appealing to those at Federal Ministry of Health that when they are forming a committee to look at things that are needed for the country to prepare for Ebola outbreak, that they should try as much as possible to include other professionals in the medical field, and not just allowing a particular profession to determine the quantity of medications, the type of laboratory reagents and all that, the nursing aspect and all that. I'm just appealing to them to, and I'm speaking from knowledge, I'm speaking from experience as being part of the Federal Ministry of Health Committee during Ebola. I was there not because I am a pharmacist by profession, but I was there because I was heading one of the medical services of one of the MDAs, major MDAs in the country. And just appealing, because if you bring in a pharmacist, for example, the pharmacist will be able to know the right quantity and type of medications that are needed, not the ones after federal government finish purchasing them, they will rot away and expire in one of the medical stores in the country. The medical laboratory scientists will be able to know the right type of reagents and quantities to be purchased. The nurses will be able to know what the physiotherapists, every aspect of, even if they don't want to go outside the Federal Ministry of Health, there are well-trained professionals within the ministry that they can pick from, or consultants in various fields of practice of medicine. So please, that is just my comment in this, that we should make a joint appeal to whoever that is forming this committee in Federal Ministry of Health to expand their net to put other professionals within that committee. Thank you for giving me the platform.
Very good
Thank
point.
you,
Very
Dr.
good point.
Aqua. Thank you very much.
Very good
Interestingly,
point.
Dr. Aqua, like Professor Tayo, is in UK now. And like other people I've seen in the house, Dupe and Lee is in the UK. Why is everybody in the UK? Professor Tayo, we need to ask you, sir. So now,
because the system works. Yes, and
now
leadership.
it's 1:02 p.m. and we're beginning to go home. I'm proud and happy to say that we have quite a spread of people here. I've seen some people from Canada, a lot from other places. I think I saw a comment from Professor Femi Oyewo, India. So many other people, if I start mentioning now, we take. I was talking about Achiever University and their network challenge, but Professor Bola Olayiwola is in the house. I've seen him and other people. Are there
Sorry,
any
Dr.
other
Lulu.
question or comment? Yes, sir?
Dr. Lulu, please. Dr. Lulu.
Yes, sir. I'm hearing you,
I
sir.
saw somebody on here from Consumer Protection, whatever, on this platform earlier on. Is the person still here that wants to comment? Consumer Protection Council or so.
Thank you, Prof. Good afternoon, everyone.
Oh, that's great.
This is Akeju, retired director with the Federal Competition and Consumer Protection Commission.
Okay, you're welcome.
And I run an NGO now on consumer advocacy and safety. As you've said, Prof, it's nice. Good morning, big easy afternoon, everyone. You see, we want to do this type of advocacy, or it should be multi-sectoral, which means all hands must be on deck, not only in the health profession. You know, when we are a business, we have the supply and the demand side. We are on the supply side. We need to get people feedback from the consumers. Yes. So their representatives should be included. There are professionals there, there are medical doctor, pharmacists there. So we can make use of them so that there'll be some voices to speak on behalf of the consumers about their rights and also the channels of communications. You know, we have to use the local language. We have to use the correct language so that they understand. People in the rural areas that we mentioned earlier, you know, some of them may not even understand English. All the jingles on the TV, radio, they may be in English. We have to be able to communicate all the way down. And we can't do that alone. We must involve the, what do you call them now? Consumer Protection Associations. We must involve the Federal Competition and Consumer Protection Commission. I'm even thinking of the National Orientation Agency, NOA. All this must be brought on board to be able to achieve the goal. Thank you.
Thank you, Ma. We appreciate your contribution. Your presence is quite good. Obi, you have a question or a comment?
It's a comment, sir. I want to say thank you for putting this together, you and your team. It's a great one. And I think I want to take it back home to ACPN so that we know our role. I know we know our role, so that we'll put our roles more into practice. Because I remember like months back, I came to Lagos ACPN meeting after attending a program like this from Geneva Learning Foundation. And I was telling them about for us to put our protocols right, our safety protocols right. So we have to really get that to work and know that it's a serious problem. Then the number of deaths were not like what we are hearing today. So we don't have to wait for this to come. We have to protect ourselves. And then as community pharmacists, the community trusts us. So we have to give them the right information
to know about Ebola and how to also protect themselves. And I will beg Mrs. Lawal to send that particular slide to us about what to do when we get when they suspect Ebola, so that we can take it round to every member of ACPN to know what. Thank you very much.
All right, thank you, Obi. Obi is the newly elected National Secretary of Association of Community Pharmacists of Nigeria. You are most welcome. We are happy to have you here. So, we've been here since 10 a.m. and I believe that we have a very good time. Professor Tayo, you are one of the first to be here, and you know that we began the conversation with a question: what must Nigeria do before Ebola arrives? And we have heard from the different perspectives, and it is now my pleasure to invite you as the chairman of the task group to help us, pieces all this together in a summary and conclusion format. Thank you, sir.
Thank you, sir. And thank you, everybody. I'm just going to spend a few minutes to summarize and make recommendations. Nigeria doesn't have much to do. That will surprise you. Nigeria already have all the factors that should be considered here, present in this arena. The most important one is the willingness of the people to toe the line. That is the willingness of the people to help the country. That nationalistic fervor that I have something deposited in me that I must make available for the use of my nation, Nigeria, to prevent unnecessary death, so that the growth of the country can be promoted. And how are we going to do that? One, thank God there is a medical doctor here representing medicine and surgery. There's a physiotherapist. There is a nurse representing nursing and midwifery. There's a medical laboratory scientist representing medical laboratory science and medical laboratory technology. They're not the same thing. There is a pharmacist representing pharmacy technician, etc. So within reasonable limit, we seem to, it's not all exclusive. There's still the medical records, which is important in terms of documentation, but we can reach them at other times. Because we have this unity of purpose, we can start a nucleus of a big and gigantic group that, whether government likes it or not, it will listen to. I'm not assuming that they won't listen. Fortunately, we have a very likable, progressive, and forward-looking Minister of Health, which we all know, Muhammadu Ali Pate. He has good credentials and he can understand our language. That is a strong point in our favor. This group that we are germinating or forming here, whether we like it or not, we are forming a brigade here now. Maybe about 6 or 7 of them do a paper and go to Pate. Pate is interested in the public health of Nigeria advances. I can vouch for that young man. I can call him young because he's not older than a child I could born, with all due respect. Go to him with this. He has a forward-looking approach to health issues. He's under pressure, no doubt about it, but let's give him the chance. We want him to succeed. We want Nigeria to succeed. If the order comes from him, knowing that we are cooperating with him and we are forming the spring ball, he will stand up and advocate for the necessary changes. Now, what are the necessary changes? The doctor has told us some things that we did not know before. We know them now. That if we had been prepared, information will have been like our airport and the ports of entry. We need a lot of capacity building there. is a necessary investment. What I experienced at the airport in June, I had a similar experience during Ebola because I was always traveling from UK everywhere to Nigeria. Each time they saw my passport at the airport, and I vouched for this, for the veracity of this statement, they saw Professor Fola. I said, "Oh, okay, come this way." I said, "No, no, no. I must also be checked. Being a professor does not mean that you cannot contact COVID-19 or Ebola. It's part of our culture. We need to deculturize people, if you can use that word, in terms of health, so that we don't, because of cultural respect, import a strange disease into the country. Our borders are very porous. I'm talking of Lagos, but if you've ever used Seme or Idiroko, which we used to use a lot during our WAPCP postgraduate college function as president, I was always transversing these areas at times. And if you're not careful, people can come in. That's one point. The other point is very valid and very germane. They need to talk with our faculties of pharmacy. They are endowed with capable people. Give them a little sum of money, they can produce hand sanitizer. What's the technology inside? There is not much. They can produce hand sanitizers for us. Some people may argue that industry can do it. They have their own schedule. We can make use of our pharmacy schools. The advantage of that is that even our students will be taught how to produce these things, and we can give them first-hand experience in the production of this kind. I'm saying this passionately because it's Ebola today. I'm not a prophet of doom, but if you follow world history in terms of progression or depression in public health, there are more dangerous diseases, and they've indicated they're coming very soon. Already, WHO even has identified emerging tropical diseases. There's a journal devoted to that already now. It started a few years back and is gaining ground. CDC in the US recognizes it, and some forward-looking CDC. We cannot shy away from these things. This is the time to be prepared. And in preparing, we must collaborate. That has been amply and severally emphasized during this webinar. The medical doctor has said it, and I was very glad medicine is saying it, because traditionally, medicine used to want to capture everything. Thank you, my dear brother, for learning. I've forgotten your surname for selfish reasons. I want to call you Folani because that's my name. The physiotherapist has said it. The nurse has said it. The pharmacist has said it. The medical laboratory scientist has said it. Now we have an open ground. Let's move on. The others are fine-tuned. Then what Mrs. Lawal said about pharmacy, and I thank God for Obi. God bless you, my dear sister. I don't know you, but I know your name. I like your approach that Shade Lawal should make that chart available for dissemination to other community pharmacies and by implication to other pharmacies. This thing is not for community pharmacies alone. Oftentimes you as a pharmacy, not in community, when people know that you are a pharmacist, they come to you with questions that usually surface at community pharmacist level, and you are bound to answer. Let's empower everybody. And like we said, when we are teaching hand washing now, we taught it at primary school. As a consultant to UNICEF a few years back, around 2002 to about 2008, we had a program for UNICEF that we were teaching school children hand washing in the old Western region. That is the Lobo states and also Bendel and Edo combined. And we were empowering young people. Such things can be done to reduce this kind of lack of hygiene. And it's not only Ebola. Last 2 weeks, we were holding a meeting online with Abuja Ministry of Health or NPCHCDA, we were talking about cholera. Hand wash is important there. We can reduce the severity and the occurrences of these deadly diseases if we train people and prepare them well. Thank you very much. That's the way I see everything that we have been talking about today. That's the way I can summarize it. Thank you and God bless you all.
Thank you very much, Prof. Let's appreciate Prof. He started all this and
God bless you, sir.
got us involved. Please, let's appreciate him. Yeah, Prof, we will want both your opening remarks and this summary and conclusion documented so that it can be part of our thing. I've seen distinguished Professor Igulo's hand up.
Just appreciate all of you. Yes, sir.
I say your hand, but Professor Tayo has started talking by that time. So
I know, sir. I know, sir. No problems at all.
So please go ahead, man. You have the floor, man.
Our appreciation goes to the president of the academy, beloved Prof. Larry Bale, our papa and mentor and father, Prof. Fola Tayo, and your very self, Dr. Lulu Ojo. Thank you, sir, for all that you're doing for pharmacy, and indeed all the distinguished resource persons. This is an excellent and well-organized webinar. And as has been said, I believe that we will be able to have all the presentations and all that have been given to us. It's the depth of knowledge, the insights, the strategies shared are highly enlightening. And I bless God for being part of this. May God richly bless and reward every one of you. Thank you so much, sir. God bless you.
Thank you, Ma. We appreciate your presence here. And Professor Mrs. Mbang, Femi was in the house.
All the way from
she has been making comments from Adrekiti, and now she wants to talk to us. Yes, ma'am.
Thank you very much, Dr. Lolojo. Many thanks. Many thanks to the organizers and all our resource persons for this wonderful webinar. Indeed, very comprehensive to the extent that we also have the physiotherapists here. And then there was also a comment on the consumers. Yes, the consumer must also be represented in all the things that we do. And I just want to thank Professor Tayo for what he said about the universities and hand sanitizers. We did it before during the COVID. Many of the faculties and the colleges of pharmacy can produce hand sanitizers. The university, you know, is very vibrant. We have a lot of students. The community itself is enough. At least that community will be protected. So we've done it before with COVID. We're ready to do it again. And our students are also conversant with it. Thank you very much. God bless you, Dr. Lolojo, for this wonderful program.
Thank you, Ma. Thank you so much. Thank you for always being there. We appreciate you. Now, ladies and gentlemen, 68 as I'm talking now. This is really very good. We promised we finish 2:30. Here we have spent 49 minutes extra. But 49 minutes that are actually giving us value for our time. So, in concluding, I want to call on the President and Council Chairman, Nigeria Academy of Pharmacy, Professor Larry Bale, for his closing remark. Professor Larry Bale.
Thank you so much, Director of Programs, Dr. Babalolu Ojo, for your kindness and for running these programs so efficiently in the last few hours. Distinguished fellows of the Nigeria Academy of Pharmacy, esteemed speakers, healthcare professionals, invited guests, ladies and gentlemen, as we conclude this very important and timely webinar on epidemic or pandemic preparedness using the case of Ebola as a focus, deep appreciation of everyone who contributed to its success. And today's discussion itself has reaffirmed a very critical truth. An outbreak may begin within a community, but an effective response must involve the entire healthcare system. Ebola preparedness is therefore not the exclusive responsibility of any single profession or any single institution or government agency. It requires coordinated action among physicians, pharmacists, nurses, medical laboratory scientists, physiotherapists, public health professionals, agency responders, policymakers, community leaders, and the general public. We must also recognize that preparedness cannot begin only after the first case has been confirmed. By then, valuable time may already have been lost. True preparedness means strengthening surveillance, maintaining reliable diagnostic capacity, training healthcare personnel, ensuring access to appropriate protective equipment, establishing clear referral pathways, managing medicines, medical supplies effectively, and medication errors, and communicating accurate information to the public even before an emergency arises. One important lesson from today's presentations is that every healthcare professional has a vital role to play. Physicians contribute to early clinical recognition and case management. Nurses remain central to patient care, infection prevention, and continuous monitoring. Medical laboratory scientists provide the accurate and timely diagnosis upon which effective response depends. We also know that pharmacists ensure the responsible management of medicines, vaccines, protective equipment, and other essential health commodities, in addition to preventing medication error and ensuring medication safety. Physiotherapists and other rehabilitation professionals support patients during recovery and help address the longer-term effects of severe illness. Our preparedness must also extend beyond hospitals. Communities are usually the first line of both exposure and defense. Therefore, public trust, culturally appropriate communication, and community engagement are very indispensable. Fear, stigma, misinformation, and indeed delay reporting can eventually undermine even the strongest technical response. We must therefore communicate with clarity, with empathy, and with credibility. On behalf of the Nigerian Academy of Pharmacy, we sincerely appreciate the chairman of the Ebola Task Force, our academic, Professor Fola Tayo, for his leadership and commitment. We also like to commend our Director of Programs, Dr. Lulu Ojo, and everyone involved in planning and coordinating this webinar within and outside the committee. We extend our profound gratitude to our distinguished speakers, Prince Elochukwu Adibo, Dr. Adefolani Opawoye, Dr. Adewale Oladayo Akinpelu, Mrs. Modupe Adesanya, Pharmacist Fola Shade Olufunke-Lawa, a mentor, for sharing their expertise, for professional insights and practical recommendations. To all our fellows, healthcare professionals, partners, and participants, thank you for your thoughtful questions, valuable contributions, active engagement. Your participation reflects our shared commitment to safeguarding lives and strengthening Nigerian health security. Very special thanks to many of you who are outside the country, many hours behind Nigeria, who had cause to sign in as early as 10 a.m. here, which is equivalent to about 1 a.m. in the extreme places like California, or maybe 12 hours earlier, like 10 p.m. in places like Hawaii. However, the value of this webinar itself will not be measured only by the quality of our discussion. It will ultimately be measured by the actions that follow. We therefore encourage every participant to carry these lessons back to institutions, to professional associations and communities. Review your preparedness, strengthen infection prevention practices, promote multidisciplinary collaboration, improve reporting and referral mechanism, educate colleagues and communities, and above all, remain vigilant. Let us remember, preparedness is not an event. It's a continuous responsibility. Vigilance saves time, but collaboration saves resources, and preparedness saves lives. The Nigerian Academy of Pharmacy remains committed to working with government agencies, with many other professional bodies and academic institutions, development partners, and communities to strengthen epidemic preparedness and advance national health security. We want to thank you once again for your participation and dedication and service to humanity. We wish you all good health and safety. God bless you.
Thank you, our dear president. Please let's appreciate him. Let's appreciate him. Yes, it's 13:26 now. So in the next 4 minutes, we'll be 1 hour ahead of what we scheduled, which is okay.
Can we request for Mrs. Akeju's number, Lulu, please? The consumer
protection.
Yes, drop your number for us.
Yes. Okay, I'll do that.
You can drop it on the chat box or send it to us. Send it to Prof or myself or our president. We'll certainly contact you. So it's been good. Like the president mentioned in his closing remarks, some people have been here so early. At least I've seen Professor Kofu Ariola in Canada. He's an engineer and he's always attending our program like this. He's been there since morning and he's still here now. I've seen a lot of people, please, if I don't mention your name, don't be angry. But a lot of people have been here. Most of our diaspora pharmacists, we've seen you. Thank you so much. From Kaduna, from everywhere. Oh, Professor Charles Simone. My prof, where are you now?
I'm here. I'm still somewhere in the globe, so I can't remember. I'm trying to recall where I am now. So I have to think where I am now. I can't just remember where I am now.
I've already begged you. Please carry me along.
Thank you, sir. Thank you. Very enjoyable webinar.
Now our distinguished professor is in the United States.
Yes, sir. Good morning from over here.
How they allow you to rest there, ma?
We are, of course, we are equal to the task, me and Daddy.
Very good.
God bless you, sir.
David and Jonathan.
God bless you, sir. Thank you, sir.
Please, is our secretary in the house? Family Kasuni, are you in the house? I've not seen him. So I will call on a member of the committee, pharmacist Abiola Polose, to please move the vote of thanks. Abiola, please. Abiola, are you there? Oh, okay. Maybe she's not there. So it's your lot again, Dr. Christiana Akpa, to move the vote of thanks. Okay? Dr. Akpa.
It's muted.
Yes,
okay.
Please.
Yes, it's there. I know. We had a lot of exchange yesterday. so many things coming for you. So go ahead.
Yeah, thank you, Dr. Loluojo, for giving me the same opportunity to say the vote of thanks. If we want to quantify the thank you that we want to say to our various lecturers or facilitators, time will not be enough for us to say thank you to each and every one of them. First of all, I want to start by saying a big thank you to our indefatigable president of the Nigeria Academy of Pharmacy, Professor Lere Bale, for having the vision to form this group of Ebola preparedness within the academy. You are making us to be like the front line or the forefront, taking the battle to the other professionals, so that to wake them up that we need to prepare, not just for Ebola, like Professor Tayo has said, but for other types of diseases, emerging diseases that might also come up in future. I want to also use the opportunity to thank Professor Fola Tayo, the chairman of the Ebola Task Group of the Nigerian Academy of Pharmacy. Thank you so much, Prof, for the various meetings that you have coordinated while we were preparing this webinar. Thank you so much. And thank you also to the Director of Program, Dr. Lolu Ojo. Thank you, because of all what your service is, a lot of sacrifice for you to put in hours to organize this webinar. I will not end this thank you without mentioning the names of our various facilitators. Dr. Adefolari Opawoye, thank you so much. Prince Elochukwu Adibo, thank you very much. Dr. Adewale Oladayo Akinpelu, thank you very much, sir. Mrs. Modupe Adesanya, thank you very much, ma. And our own pharmacist Folashade Olufunke Lawal, thank you so much for the high quality of slides that you people prepared and the information that you have transmitted to us this morning. We will go back to our various walks of life to think about how to impact our community on this preparedness, because if we are not prepared, we will be overwhelmed. On a final note, I want to say thank you to everyone who has attended this webinar. Without you attending this, we will not have achieved what our intention for organizing this webinar is. Thank you so much, and God bless you all. Thank you.
Thank you, and let us thank her too for being around and for moving the vote of thanks. Thank you so much, everybody. Thank you. I've seen all of you. I've seen Fumi Awuyemi. I'm sure she's either in United States or Canada. Everybody is just getting out of the country. I've seen a lot of, and Leah Tabo all the way from Sokoto. I cite you there. Sakari Jia, nice to have you around. Just calling randomly. Oh, my dear sister, Mrs. Fola Tayo Motoyinbo, nice to see you here.
God bless you, dear.
Yeah, I always see you and I salute you. Oh, Dr. Meze Okolo, my dear brother, thank you for being around. We actually need you here.
Thank you, sir. Appreciate it, man.
Yeah. Yeah.
Thank you, Dr. Lulu. We appreciate it.
Are you still in Ado-Ekiti or where are you? Nice to see you. Yeah.
I'm on my way to Canada.
Yeah, see, look at you.
Lulu, I told you now.
What's chasing you in Ado-Ekiti? Professor Yewo is there now, so why are you running?
No, don't worry. Yewo is in the academy, I beg. Leave them, now then they enjoy.
Academy, they enjoy.
Great, Jima, our press consultant. I've seen you. Now I know you can now have a very good package. That's the young lady who was asking me about the physiotherapist, and it's now our job to take this from the discussion we have made to now take it to the public. And I know you are going to do a good job of that.
Very good.
You're going to do a good job.
Yes, sir. Thank you, sir. Good afternoon, sir.
Yeah, I saw you when you came in. You came in early. You know, Khadijat, long time. Nice to see that you are there now. Professor Ariola, good man. Thank one of these days you have to speak to us because you have experience all over.
Okay.
Lawumi Peters, my dear sister, where are you? Lagos or Nigeria or UK?
Ukraine,
in the world.
You know where? How can I know where you are? You could have traveled. MAM, I've seen you. Mrs. Okewale, our director. Director of Pharmaceutical Services, Lagos State. We have seen you here. Thank you so much. Yes, she's there. Olabisi Okewale is there. You know, Shola Deniola, nice to see you. So what happened in Kaduna? What happened to the network?
Thank you, sir.
What happened to the network eventually? Eventually, you are able to make it. You are muted. Okay, we are happy to see you because we have assignment for you, but network will not allow. Prince Adibo, we have noted you, so don't be surprised that you'll be receiving invitation from us. Your presentation was really enlightening.
Well done, sir.
Afusat.
Well done, Daddy. Sir,
how are you?
Good. Fine, thank you, sir. Well done, sir.
Thank you. My college president, nice seeing you here.
Yes.
Okay. Oh, somebody is even just asking to be admitted now. It's all right. She will meet greeting at least. We meet greeting. Fatima Adeyemi. Oh, that's true. Now, Grace, we're happy to have you. So thank you, everyone.
Okay, thank you. Well done.
Thank you, Prof.
More grease to your elbows.
Thank you, sir.
I'll call you in your Iluoke that you are in now.
No problem, sir. You can give us invitation to the city.
Oh, you can come. I'm in London. You know that Wigan, I used to drive past that place to Glasgow in the 60s.
Because you still have to pass Wigan going to Glasgow.
And M74 was just being built then. So from M74 from
I may go from here. I may go from here to join Professor Simone in Burundi. Wherever he is, because
don't go to DRC, please.
Each time I call him, he says,
Charles, are you in Burundi? Or,
yes, sir. Yes, sir. Yeah, Prof, sir.
Okay.
Prof, sir. Don't mind Lolo is pulling my leg. Lolo just pulling my leg. So I've resisted this pulling of leg. He wants to come and join me suffer. I say big man cannot come and suffer. It's not good. Our culture does not want big men to suffer. Why do you want to come and suffer?
I saw this current posting, and I say, you've been flying around.
Don't go to DRC.
Yeah, I saw a recent posting.
No, not suffer.
You finish Vice Chancellor's job. You finish Vice Chancellor's job here. They pick you up for another Vice Chancellor's job.
More work now, more suffer, more work, more suffer. Yes, sir. Thank you, sir. Thank you, sir.
The Lord will uphold you in Jesus' name.
Amen. 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 Thank you.
Thank you very much, everybody.
Oh, yes, thank you, sir. Amen. Thank you.
We may have to shut it down. We have to shut the platform down now.
Yes.
Amen. Thank you.
Take care.